Yes. Welcome, Integrity. We're here getting ready to finish out Chapter 22, which is blood vessels. Yeah, blood vessels. Then we'll start on respiratory today. No, we're finishing respiratory, then we'll start on digestive today. But before I do that, I wanted to bring up the idea that as close as we are to the end of the semester, if you have not done a lot of work on your coloring, it's a great time to finish that up. And I would recommend anybody who's not setting already on a perfect A to just do the coloring. Why not? Because it's page 70 to 170. That's 101 pages for the math challenged. If it was 70 to 170, that can't be 100 pages because we didn't start on 0. We would have had to start on 71 for it to be 100. So the 0th page becomes page 101. So 101 divided by 4, which is how that coloring formula works. Do 4 pages, you get a test point. Effectively gets you 25 1/4 points. The quarter point may or may not help you, I don't know. But just by way of figuring out where you are in the grade scheme, a couple of things. There are, or will be, by the time we're done with this semester, 5 exams. We've already had 3. We're doing 1 more this weekend. There's going to be the final. It's a total of 5. I'll drop the lowest test grade. I've already told you that. Mastering average comes in place of that test grade. So we're back to 5 grades. So I'm going to take your total number of points and divide by 5. We haven't dealt with the coloring yet, though, and that's going to be 25 points if you do every single page. So if you want to, it's not how I'm going to do it, but you can think of, I'm dropping the lowest, putting in mastering instead, and dumping 25 points on top of your next lowest test grade. So think of it that way if you want to. It's not exactly what happens, but mathematically it's close enough that it'll make very little difference. If you've got a 75 for a low test grade, it becomes 100. So, yay, that's not a bad thing. And again, that's not exactly how mathematically I'll treat it, but if you want to think of it that way, then yay. Now, wow. Probably shouldn't have had that shot of espresso before I walked in the door.
When is the coloring book due?
It's due the day you take the final. You can turn it in early, but I'm not going to record them until the day of the final when I've got a big stack of them in front of me, and I'll kind of grade them all at once. The good news is the way I have you turn it in, I can grade them in just no time at all. So while you're taking your final, I'll have them graded by the time you're done. So you can walk out the door with your coloring book. I'd really prefer that I don't keep it, that you have it the whole time. That said, occasionally the question still comes up, how do I figure out what my grade in mastering is? And the short answer is, I don't have an easy answer. Desire to learn is based on the point system. You know, you get so many points, and it's easy because 5 tests are worth 100 points apiece, so 500 points divided by 5 is your grade in desire to learn. The mastering grade book, by default, and I can't change it, or believe me, I ever so much would, is a percentage thing. And until all of the assignments are done, I honestly, frankly, I have no freaking idea how to calculate what your grade is. What I would suggest is kind of mentally as you go through, you should have by now, or you can go back and look, see what percentage you got on each one, because I think it told you all the way through. Like you got an 83 on this one, you got a 72 on that one. Was it telling you something like that? So kind of keep running total in your head, and if you're mostly getting in the 80s and the 90s, then you got like an A or a B, which is going to come out to somewhere in the 80s or 90s when I record it. I don't know what your own personal grades were, so don't just assume I just told you you have in the 80s or the 90s, because your mileage may vary. But you've been getting those reports all along, and you probably have some at least vague idea where you are. And if you're sitting on a test that's like a 47, you know all that wonderful happy stuff on mastering is going to come take the place of that ugly grade. So, yay, hopefully that'll help you. I can't give you an exact number because mastering is not set up to let me do that. If it were on points, we would do that. And I probably ought to get past this start here as soon as I answer Zach's question.
You remember last semester when you opened up?
I'm going to do that too. Yes. Yeah.
Because I missed like 3.
Yeah, I know. I know. And a few of you have sent me emails saying, hey, I missed this one, or hey, I missed that one. Could you please open it up for me? And I've steadily ignored you because I don't want to open up a dozen individual varied assignments for individual people, because I knew that later this week, probably tomorrow or the next day, I'm going to give you that get-out-of-jail-free card where it says, okay, every single assignment is open all the way to the end, including that one that was extra credit. So you can come back in and do those if you want to. And it's, again, tomorrow, the next day. It's going to open up sometime in the next few days. And I'll give you, I'm not sure, probably a 24, maybe 48-hour period to come in and knock all that stuff out. So if you missed anything along the way, you can come in and catch up. Whether it's on the homeworks or the end-of-chapter test is fine. So thanks for asking. Yes, it's going to happen. All right. With all that said, let's get rolling. We've got lots to do, miles to go before we sleep. And we're going to need the camera right away, so let me wake that up. The question just got asked, how many questions on the online test that wakes up this Thursday? There are 72 questions, and I went ahead and I gave you a full 2 hours on that. It's kind of padded out. It's more time than you really need. But, you know, at that point, you've kind of got no excuse for not doing relatively well on this one. So knock it out of the park. I expect from that there probably won't be any curve, because with that kind of time, you guys generally perform really well. Okay, larynx. We're continuing our discussion of the respiratory system, and we're going to look at one on the camera here in just a moment. The larynx basically is a valve to keep things out of the airway that don't belong in the airway. It provides what a medical team would refer to as a patent airway, which means it's, you know, all the tubes are open, air can flow. It also acts as a valve to determine that food and air go in the correct channels. Mom told you long ago, don't talk while you're eating, and boy, was she ever correct, because the larynx acts as a valve to keep things out of the airway that don't belong in there, like, oh, I don't know, corn kernels or green beans or Kool-Aid. And it also is involved in voice production. There are 5 major cartilages, well, 5 kinds. Some of them are paired, some of them are singular. And I want to have you know most of them, although one of them is hard to find on our models. So we'll talk about the 2 that are not paired and the 3 that are paired. The hyaline, hang on. They are all made of hyaline cartilage, except for the epiglottis, which is other stuff. The cartilages made out of hyaline would include the thyroid cartilage, a cricoid cartilage, arytenoid, cuneiform, and corniculate cartilages. All of those are made of hyaline. So hyaline is the material of which those are constructed. The last one, made of something utterly different, is the epiglottis, and it's made of elastic cartilage. The same stuff that makes your upper part of your pinna of your ear floppy. Actually, not floppy, relatively plasticky rigid. So the the thyroid cartilage and the cricoid cartilage are singular. So let me do a quick little in red 1 next to those. Cricoid cartilage is singular. The thyroid cartilage is singular. But the arytenoids, cuneiforms, and corniculates are each paired. And I'm going to show you those on the model and on a diagram here in just a minute. And the epiglottis we'll certainly take a look at too. Keep in mind the epiglottis is made of other stuff. But let me show you this graphic first, and then we'll look at the camera. The thyroid cartilage is this one right here. It looks very much like the prow of a big old ship, and it is very prominent. It's what in most individuals' necks you would refer to as the Adam's apple. Underneath it, and I'm going to do a little outline in green on this one, we see the cricoid cartilage. This one's interesting because it's the only one that actually is a complete ring. Most of these cartilages have an open back, but this one is very much a complete ring. I'm going to turn this on its side, and in this view you can see that this comes all the way around to the back. Now they've cut this in half, but it's the same on the side that's been cut away. So that's, again, the cricoid. Where did that go? Okay, there's my label over there. They moved my labels. I hate when they do that. And then the thyroid on this one is here, and it wraps around. We can't really see much over here. So there we go. That's the back side of the thyroid. Again, back on this view, we have a thyroid in red and a cricoid in green. And here we can see the other cartilages. Everything else I'm about to do, I'll do in, I guess, maybe purple and orange and yellow. We'll go purple first. This one right here is the biggest of the paired, and it's called the arytenoid cartilage. You're about to see these on the graphic, so hang tight for just a minute. This little teeny tiny tip here, bright orange, is the corniculate. And the word cornu means horn. Like the sharp, spiky thing coming out of the side of a bull's head. So bullhorn, cow horn, same kind of idea, and that's the corniculate. The one that we unfortunately don't see on this model is the cuneiform, and I'll do that one in, I guess, bright yellow is what I've got left here. This one we do not have on our model, so you might find it on a graphic, but honestly, as we come into this last test where I've got so much material coming at you, I probably won't even try to find it. I'll be more likely to ask you this from a model. Keep in mind our final, which is going to be after next week, is going to be back in the classroom, so you're looking at real models here for this stuff. So back over here on our camera, this is a larynx model. And to keep this so I can get everything on screen, I'm going to back this up a little bit and use my pointer. This is the thyroid cartilage. And as I turn it, the model on the side, you can see that this thyroid cartilage wraps around on the side, and when we get to the back, it stops. So there is no back to this. It's just open in the back. You can see this edge and this edge, and there is no thyroid cartilage in the back. If I continue to rotate, we're back at thyroid cartilage again, and we're back around to the front, which looks like a ship's prow. And again, that's like the Adam's apple in your throat. Just below that, right here, between these two pieces of muscle, that's the cricoid cartilage. This is the only one that's a complete full ring, and it goes all the way around the airway. So here where my thumb is, that's still cricoid. Here, as I continue to turn, this is all cricoid, and it actually goes up like the backside of a low-top tennis shoe. If we could get these muscles out of the way, that would help, but I can't, so I'm not going to bother to try. And it continues all the way around here. This is cricoid, this is cricoid, this is cricoid still, and it comes all the way back around to the front. So those are the two that are not paired. The ones that are paired that you can see on this model, we have to turn to the back to see. And I've got to get this thing up out of the way. That's the epiglottis, by the way. More about that in a minute. Kind of a little door flap. And I'm actually going to hang the camera off the side of this larynx and have you look down inside. Do you have an idea where we are here? We're on the top of this. I'm coming in. We're looking at these two horn-looking things on the very back. Sorry for the Linda Blair dizziness thing. What I'm pinching right here are the arytenoid and cricoid cartilages. The bigger one is the arytenoid, and that's what my thumb is kind of rubbing over. You see the little black line there? That little sharp, pointy tip is the corniculate. And again, cornu meaning horn. It's like the little sharp, pointy horn tip. So the corniculate and the arytenoid are right here. I think I said cricoid a little earlier, and I did not mean that at all. So this big thing is the corniculate. Ooh, see, we're peeking inside. And those white things, vocal cords. Again, we're on the very top of this. Down on that view, kind of give you an orientation. We're coming up over the top of it. We're on the top of it, and now we're looking down inside. And anybody care to guess what those white things might be? Any guesses? Vocal cords. Those are your vocal cords, and the opening there is called your glottis. So the glottis is the opening to the airway, so we are looking down inside the airway there. That's actually the view that you would have if you were putting in an intubation tube, a breathing tube for somebody going into surgery or coming out for trauma. And that is protected by this flap, which is the epiglottis, and that thing lowers anytime you swallow food. The weight of the food pressing down on the epiglottis closes it. That, by the way, is the other unpaired cartilage, but it's the one that's made out of elastic cartilage, not hyaline cartilage. So whenever you swallow something, it closes and protects the airway. And this model has got a little string holder that you can hold it down. You probably wouldn't want to do that, or you would yourself choke. Yes?
So people get injured and have problems like most of the time.
Mm-hmm.
Is it because that structure gets messed up?
It gets inflamed, yeah. As they scrape that tube past those vocal cords, it does tend to irritate them. Yes, absolutely. Nice hair change, by the way. Made him look. Okay, vocal ligaments. Those vocal cords that I showed you to. These are attached to the arytenoid cartilage and to the thyroid cartilage in the front. They have elastic fibers in them, and they are the core of your vocal cords. And we would call these the true vocal cords. And the opening between them, which I showed you as I had the camera in there, is called the glottis. And they vibrate to produce sound as air goes past the lungs. So back over there. Oh, we sort of have a view of it there. I'm going to actually come in here in a bright red and draw in the vocal cords. So this would be a vocal cord or a vocal fold or a true vocal cord. And they showed up in the model that I just had up here a moment ago. I do want to bring up a different model to show you, though. Oh, and while I'm doing this, I want to be just a little bit disgruntled. And I'm going to tell you about being a little bit disgruntled to point something out that might be useful to you. You all know that I had to make a working trip this past weekend, and oh, sadness of sadnesses, the working trip was in Vegas. And Friday afternoon, in the middle of the meeting, I was answering some of your emails and resetting some stuff on mastering. And I jumped every once in a while. I'll make a jump over to a website that I check a few times a semester called Rate My Professors. And if you've never had the chance to look at Rate My Professors, it's kind of an interesting site. You can leave comments about people that you particularly enjoyed or that you really, really hated and you want to warn people away from. And generally, the postings over there are fairly good. Pardon? Pardon? Cool. I like that. By the way, I'm particularly disgruntled that in the last few years I've got no hotness peppers, so oh well. In spite of having lost 25 pounds. But I get it. Don't go post on hotness. But anyway, I had a whole lot of fun comments over there over the years, and probably one of my favorite from about 5 years ago was that he's got enough technology in his room to run the Mars rover from his class. And frankly, I don't disagree. But there was a post made in the last semester, during this semester, which presumably is from somebody in the class. And considering the antics you and I just gone through, I mean like hovering over with the camera, the comment was he puts up PowerPoints, highlights the words on the screen, and reads the words. And I thought, has this person ever sat in my class? So if the person who posted that is here, talk to me if there's something that bugs you, because holy crap, that's not what I thought I was doing. If I'm just highlighting and reading the words on the PowerPoint, somebody stop me somewhere. Put a bullet in my head. Don't really put a bullet in my head. Let me know. I'll retire and I'll go make chocolate or something. Oh, yeah. Oh, yeah. I've had classes like that, and they make me crazy. On the other hand, if you're happy, go post other stuff, so that one gets ignored. Okay, now, that's true vocal cords. Let's go up just a little bit. And I want to go in bright green. And I want to talk about that ridge right there. It's a vestibular fold or a false vocal cord. You can see both of those on this model. We got to kind of jump down on this one. This is a tracheobronchial tree, and you can kind of see why it's called a tree from the way it looks. Now, what I want to do is I want to take this top part in half. You're welcome to do this as you study this model, but please be careful. When you start to pull this top part in half, there's a plastic pin, and that plastic pin breaks easily. There's one right there, and there's another one down here. So lift gently, and it'll pop right out. But if you bend it, it will break. And this is about a $300 model, so kind of be careful with it, if you will. What I wanted to show you on this is this component here. This white strand right here by my thumbnail is a true vocal cord. That ridge right above it, right there, is the false vocal cord. And it causes a neat little phenomenon called a laryngospasm. Oh, God help us. Laryngospasm, you probably have experienced it at least once or twice before. If you are drinking and somebody makes you laugh in the middle of that drink, and all of a sudden you inhale this little misted or dropleted particle of liquid, and it lands down in there, it causes those vestibular vocal cords to slam shut, and then you're going trying to breathe, and you can't because you've got that laryngospasm that is causing you to not be able to breathe. Were y'all able to see the camera? I thought I was showing it. Yeah. Oh, okay. All right. Good. Anyway, those false vocal cords, and you can find them very well on our models. Yay, we did that. And yes, I just talked about that. They're above the real vocal cords. They have no part in sound production, and they help to close the glottis during swallowing, and they cause the dreaded L-A-R-Y-N-G-O spasm, which people really don't want to experience. It's not a fun thing to have. Hey, there's that nice little view. If you were intubating somebody who was in a trauma or about to go into surgery, this is the view you have with the laryngoscope as you try to put that tube down in their airway. What you're trying to do is force open the true vocal cords, which are right here, and then the airway would end up right in here. This is the back of the tongue. Yes, ma'am?
That's why it gets so funny, because it doesn't, it's open in the section.
Yes, yes. Now, they'll generally, I'm assuming, lubricate that, but I don't know since I've never actually done that. You can actually see the vestibular folds, those false vocal cords right there and there. Not to be terribly crude about it, but if you want to put a visual analogy on this, it's a little bit like false vestibular folds or false vocal cords being like labia majora, and the true vocal cords like labia minora. We're going to get to that topic in another few days anyway. So visually, there's a little bit of analogy there, the inside and the outside ridges. Now, when you're talking, what's causing that speech is expired air that you breathe out vibrating your vocal cords. And the pitch of your voice is determined by both the length and the tension of your vocal cords. We just looked at the thyroid cartilage, and I mentioned, I think, if I didn't, I'm about to, that the thyroid cartilage tends to be bigger in men. So men tend to have longer vocal cords. And if you've ever strummed a guitar, if you hold the strings way up by the top of the neck and then strum the strings, you get a low-pitched sound. On the other hand, if you bring your hand down by the bottom of the guitar and pinch the strings and strum them again, shorter strings vibrate at a higher pitch. So people with longer vocal cords, i.e. men with big Adam's apples, really, really long vocal cords, tend to have a lower voice. Women have higher pitched voices. Children who have little bitty short vocal cords have the highest pitch voice of all. So length has a variation or an ability to vary the pitch of your voice, as does tension. You can tighten up your vocal cords, and as you tighten them and tighten them and tighten them, the pitch of your voice goes higher and higher and higher. Yeah, that hurts. Pardon?
Is that when the voice, is that causes the voice?
Yes, because as they get their growth spurt, part of that is human growth hormone, and part of the growth process is the larynx gets longer front to back, and their vocal cords get longer front to back, and as their vocal cords get longer, their voices get deeper.
I have two boys, I hope it hurts.
Yes, indeed. Or they still have high-pitched voices?
Yeah.
Yeah, it'll get better. It'll get better. How old are they?
Almost 13 and 11.
Ooh, guys, Mom's picking on you. No, it'll happen. It'll hit quick. Loudness depends on how much air you're pushing out. And then, of course, when you're dealing with voice production, the space of the pharynx, the spaces of the mouth and nasal cavity, and the sinuses all amplify and enhance sound quality. I'm not going to hold my nose and talk again. I did that last week, and once was enough. Sound ultimately then gets shaped into sounds of language by moving around your pharynx, your tongue, your soft palate, and your lips. And you're familiar with that already. You can do things like oh, ee, ah, ah, ooh. Yay.
What causes your voice to squeak? Like, you know how whenever guys are going through
That's because as you're talking, you can do really random things like this. You have to learn to control the tension of the vocal cords. And it's a process. It's kind of like, in fact, you may have experienced the flip side of that problem. Young girls tend to get their height earlier than young boys. So somewhere around 5th, 6th grade, you'll look at a class and the girls tower over the short boys. And in that growing of height, legs and arms grow out of proportion, and sometimes young girls have an age where they're particularly clumsy as they learn to operate longer legs. And boys have the clumsiness with their voice as they learn to operate the longer vocal cords. It's kind of a same problem, different manifestation. All right, wind. What? Windpipe from larynx. We're talking about trachea now. We need to come down below the larynx into the trachea, which is this structure here, from the larynx down to the split in the Y. That's your trachea. Well, that's kind of cool. Since I have this picture up now, let me show you that these blue things are kind of like, but they're not really, rings of cartilage. They're also hyaline cartilage. But there's an interesting thing about these. From the front, they do appear to be rings, but the hidden secret on the back is that they are not rings. They're actually C-shaped trying to snap this back together. I probably ought to just take that off out of the camera range, snap it back together, and get this out of the way, and hold this up and show you that in the back, the blue of the cartilage kind of comes to an abrupt stop right there, and the back is actually open. Well, it's not open exactly. This smooth part on the back is a muscle. Very cleverly named muscle. By the way, what's the name of this tube again? Trachea. The muscle right there is the trachealis. Not hard to keep straight. But these rings are not rings. They're C shapes of cartilage. Oh, and at the very bottom they split into these two right and left primary bronchi. One tube would be a bronchus. See the very last piece where the split happens? It is an interesting structure with its own particular name. It's called the carina. So the carina starts where my fingers wrap around and end right here. Looks for all the world, as soon as I say this, you'll never not be able to see this. Looks for all the world like a pair of panties. You got the waistband and the leg holes. You see it? And in this particular example, apparently crotchless panties. Wow, I just caught that. And if you turn it around, the back has been blown out. Holy moly. Anyway, that's the carina. And an interesting feature of the carina, besides the fact that it splits into the two primary bronchi, yeah, he just reads words off the page. The particularly interesting thing about the carina is anything that gets in the airway above here, a little kernel of popcorn, maybe some water, maybe a little bit of dust, anything that is in here initiates a cough reflex, trying to get it back out. But if that item falls below the carina, you have no more cough reflex at that point. Effectively, the body has just given up and said, to hell with it, I can't cough it that far. So anything above the carina, you'll have a cough reflex. Anything below the carina, it's just in the lungs from that point until the body manages to either wall it off or clear it up. Yes, yes, absolutely. That's where you get concerned about friends aspirating. I love it. I have a text message from my wife. I'm bored. Apparently she's between patients right now. Okay, so there's the trachea. Its wall is composed of 3 layers, and at this point, in the interest of time, I'm going to mention quickly mucosa, submucosa, adventitia, inside to outside. Yay. The trachealis muscle is going to make up the back part of the airway. It contracts while you're coughing to help get rid of mucus. And the very last bit, which I showed you just a moment ago, is called the carina. It's the very last tracheal cartilage, and it's the point where the trachea branches into 2 bronchi, and it's also the point where the cough reflex stops. So anything below that will simply fall on down into the lungs and either be handled by the body's immune system if it's small enough, or it may be encysted and end up causing a little scar. This is a nice little cutaway, and you can see the 3 layers. You have the submucosa here, shown in pinkish reddish. Then we have the hyaline cartilage, and then we finally have the adventitia out here. Behind this, by the way, is the esophagus. And here's part of the reason why this is not a ring of cartilage, but instead it's a C shape of cartilage. That esophagus, of course, is the tube you're going to swallow food through, and we're going to get to that in a few minutes. What would happen if let me just borrow some blue ink and kind of sketch this in the way you do not want it. What would happen if this was actually a ring of cartilage and it came all the way back around here? What would happen every time you swallowed food? My point is, why is it soft in the back instead of hard cartilage? Pardon? Yeah, it'd be hard to swallow. It would be hard to swallow, and rough food, things that were particularly hard, not sure what they would be. Can you hear it? Would rub the inside of the esophagus. So instead, it's smooth in the back, and as food comes down your esophagus, it's nice and smooth. So you don't want that rough ridginess like a washboard, or you would abrade away the lining of the esophagus. Interesting thought, but yay. Right, bronchial subdivisions. I showed you already that this is kind of Y-shaped. The first 2 branches after the carina are referred to as primary bronchi, and that's the first branch. We actually have 23 or so orders of branching. In other words, here is the first branch. And then over here's another branch, that would be 2. And over here's another branch, that would be 3. And over here there's another branch, that would be 4. And it continues about 23, 25 times. And ultimately we get down to the very smallest level. So it's kind of like looking at bunches of grapes down at the very bottom of the levels. So we have a trachea, which branches to right and left primary bronchi. By the way, bronchi is plural, bronchus would be singular. Each main bronchus goes into the hilum or the internal indentation of one lung, right or left. The right primary bronchus is wider, shorter, and more vertical than the left, which means the left one is going to be skinnier, longer, and less vertical, more horizontal. Each main bronchus is going to then branch in the lungs into, stop it.
Does that have to do with the position of the heart? Is that what
Yes, absolutely. Yeah, in fact, I'll show you that on that left lung model here in just a second. Each main bronchus will branch into lobes, and you actually have 3 lobes to the right lung and 2 lobes to the left lung. We saw that the other day. And each lobar bronchus will supply 1 lung lobe. Now, once we get over into individual lungs, the lobes separate into segments. And we call those tertiary bronchi. And we can actually see the tertiary bronchi in the model that's on the camera but not currently visible. And those segmental bronchi will continue to divide. At this point, I think we've branched about 3 times. And these will continue to divide another 20 or so times. If we get down to a tube that's a millimeter or less in diameter, we call it a bronchiole. And the smallest of the bronchioles are less than 1/2 millimeter in diameter. And you can kind of see that here. What we're seeing here are 2 pink lungs. The one on the right has 3 lobes. You can see the lines dividing those. The one on the left has 2 lobes. Oh, let me show you, since we're here, a left lung model. Oh, focus. Right there. You can tell it's left because we have this nice dividing line separating us into a top part and a bottom part. We only have 2 lungs. And to answer your question, here on the left lung is the cardiac notch where the heart would fit. And that's partly why this one is smaller. And you can see right here you have that left primary bronchus entering the lung here. And of course, since this is a plastic model, we can't see inside where it's continuing to split because on the plastic model it's not. So here we see primary bronchi, which I'll highlight in red. Here would be the right primary bronchus. Over here would be the left primary bronchus. It's more horizontal than the right one was and a little bit longer. And then those would split into secondary bronchi. So that was our first split. Here's our second split here and here. And then this one's going to split here and here. Well, actually, no. Sorry. Here and here. And then each of those would continue to split. And God, please don't make me continue to color all the splits. And you can see the carina looking like underwear right there. All right. Some of these airways have cartilage around them. And those are referred to as conducting zones because their walls are too thick for gas to go through. This is all the way from bronchi down through bronchioles. And as we get farther along in the branching, the tubes get smaller and smaller and smaller. The cartilage rings give way to plates of cartilage. And finally, in the smallest of the bronchioles, there is no cartilage. So that thick, almost plastic-like cartilage is gone from the smallest of the bronchioles. The epithelium, as we go farther and farther down, switches over from pseudostratified to cuboidal. Pseudostratified has got a lot of cilia and a lot of goblet cells. Goblet cells, you might remember from histology, make mucus. And as we get farther down in the branching, we have fewer and fewer goblet cells, fewer and fewer cilia. So there's less and less mucus as you get farther down, which is kind of good because the mucus is there mostly to trap dirt, debris, bacteria, dust very high in the airways. And by the time you get farther down, presumably most of that's been filtered out already. The relative amount of smooth muscle increases And as we get even farther down, we come to what's called a respiratory zone. This is tubes with thin enough walls to permit gas exchange. This would include respiratory bronchioles, alveolar ducts, and alveolar sacs. Respiratory bronchioles actually can have oxygen or CO2 going through them, as can alveolar ducts. And alveolar sacs, or air sacs, are the smallest structure in the lung. They look for all the world, and you're going to see this in a picture in just a minute, like clusters of grapes on a stem. You have approximately 300 million air sacs or alveoli that make up most of the volume of your lungs. And I don't know that I've seen any real data on this, but I know when I first started learning respiratory anatomy in my first undergraduate courses, the instructor who taught me this made this statement, and I've never seen anything to really back this up, but I've got no reason to doubt him. He was an insanely smart man. That if you were to take all the membranes of your lungs, your two lungs, and unfold them very carefully like you were unwrapping an entire box of Kleenex, you have enough respiratory membrane to cover an entire tennis court. It's a lot of lung. So when I say 300 million alveoli, that's kind of what I'm getting at. Yes, ma'am?
Since we're on lung, we were talking about in my psychology class today about a kid who drowned in his bed. He went swimming with his mom.
Who drowned in the where?
In his bed.
Oh,
He went
okay.
swimming with his mom.
Right.
And whenever he went to bed, there was so much water in his lungs he was drowning while he was sleeping.
Interesting.
Yeah, we were talking about that.
Yeah.
It doesn't entirely surprise me, because effectively what happens when you drown is you have so much water filling the lung space that gas exchange can't take place. I haven't heard the story. I'd have to see the details. Kind of the typical scientist, show me the data and then I'll believe it. But I don't doubt the story at all.
Can renal failure do that to you?
Pardon?
Would renal failure do that to you too? You could drown in your fluids?
Yes, it can. Yes, it can. Yeah, if you stop clearing fluids, you can build up. Yes. Haven't seen the story, can't vet it, but it doesn't surprise me. These air sacs are the main place for gas exchange to take place. All right. Here we see, presumably down around that 23rd or 24th branching, the last branch ends in these air sacs or alveoli. And you can see in this picture how they do look kind of like clusters of grapes. So we have terminal bronchioles, respiratory bronchioles, and alveoli. And all of this is part of the respiratory zone. Gas exchange can happen at any place in here. The tubes are thin enough. There are certainly some straps of smooth muscle around them. Oh, by the way, for those of you who have experienced asthma or know individuals who have, these straps of smooth muscle are what have the ability to constrict and irritate asthma. Now, as we look a little closer, in this picture, especially here on the right, the cartoon image, you can see that these air sacs are interlaced, much like a big pile of soap bubbles in a bubble bath. They kind of join together, and there are even little round openings connecting them called alveolar pores. So this is sort of like one big meshwork or maze of chambers. Their walls are as thin as it is biologically possible to be. Their walls are one single cell membrane thick. The image on the left is a real photograph of a histological section of lung seen under the microscope. Now, next we'll talk about the respiratory membrane. This is a half of a micron thick, and it is an air-blood barrier. So it's one of these air sacs, and right next to it is one single capillary, and both of them are one cell membrane thick. So effectively, what a respiratory membrane is one alveolus and one capillary joined, and their basement membrane is basically one shared basement membrane. The wall of the air sac is a single layer of simple squamous epithelium, and these are cells called type 1 pneumocytes. That ought to be one word, and it didn't quite fit before I ran out of space to write. Pneumocyte. There are scattered in amongst them some type 2 pneumocytes. Type 1s are squamous, type 2s are cuboidal. And the big thing about type 2 pneumocytes is they secrete a very slippery chemical known as a surfactant, along with some antimicrobial compounds. But the surfactant is the big issue here. I think we're going to see a picture coming up in just a few minutes, but I want to talk kind of quickly about these type 2 pneumocytes. And I can relate this to something that probably has happened to you. Imagine, and this would be a stupid thing to do, but you can probably imagine it. Imagine having a box of fake brand Kleenex. Let's say you had a really, really bad head cold and you had to blow your nose a whole lot, and all you could get hold of, I'm not sure why this would be all you could get hold of it, but just assume a box of, let's just say, dollar store Kleenex-like tissues. You know, they're kind of the cheap and cheesy ones that whenever you put one up to your nose and blow, you end up with more junk on your hand than in the tissue. And imagine that entire box got somehow wet with water. And now, God knows why, because you're particularly picky, I guess. You decided to open the box and separate all those tissues and lay them all out so they could dry so you could reuse them. I don't know why you would ever do that, but hopefully you can imagine. How big a pain in the butt would it be to peel apart all of those wet tissues from each other? Kind of a pain, ain't it? They tend to tear, they stick together. Your air sacs, your alveoli, are designed to never collapse. Because if they do, those membranes have the potential to stick together like wet Kleenex. You, for the most part, have never had that happen. For a reason we're not going to get to with some really interesting physiology. As you inflate and deflate your air sacs, you generally never empty them completely. But at least once in your life, you have gotten to the point where those air sacs did collapse. And it was that moment. And it's a different moment for everybody. For me, it was in second grade. I was on the monkey bars in the playground, and the little poop Malin Ward, still remember his name to this day, tackled me mid-air, hit with his shoulder right in the back of my knees as I was on the monkey bars, one hand out in front of me, one hand out behind me. He hit me behind the knees, and I came off the monkey bars and landed on my back. And I lay there trying to get my breath, and you probably have been there at least once. You go, trying to inflate your lungs. How many have been in it, not with Malin Ward or something like that, might have been in a spot with the breath knocked out of you? Okay? You know how hard it is to fight to get your breath to make that happen? What's happened is those air sacs have collapsed. You, as a walking around functioning human, have perfectly healthy type 2 pneumocytes making surfactant. And it's a slippery liquid, and it helps those membranes peel apart from each other. Here's the deal, and it's why you might have sort of in the back of your head had this niggling familiarity with the word surfactant and type 2 pneumocytes. Premature babies who are born before their time are often placed in incubators, and the phrase that you often hear is their lungs aren't mature yet, or their lungs aren't grown enough yet to be outside. They aren't. Their type 2 pneumocytes have not yet developed, so they do not make their own surfactant. How many of you remember how scary it was trying to get your breath on that time? All right, imagine if every single breath you took was that hard to take. That's what premature babies face, because as they breathe out, their air sacs do collapse, and they have to fight to reinflate them. So generally, in that incubator that they're in, they have a humidifier, or sometimes even more advanced, they've actually got a breathing tube that pumps into their lungs pre-humidified air that has got little micro droplets of artificial surfactant in it, until their lungs are mature enough to make their own slippery stuff so their air sacs don't slam together. So if you've ever heard that story of a premature baby's lungs not being mature enough, that's what the deal is. They need to be kept going long enough to give their lungs a chance to make their own type 2 pneumocytes to produce their own surfactant. So if you've heard that story and wondered what was immature about their lungs, it's that they did not have enough type 2 pneumocytes. Does the idea make sense? Can you imagine what it would be like if every single breath you took was like that? I'd be saying, dude, put me back in for a while. I'm not done baking. Here is the respiratory membrane I've been talking about. You can see the terminal bronchioles, the big red tube in the top left corner. It branches into our respiratory bronchioles, which end in dozens and dozens of little air sacs looking for all the world like clusters of grapes. Now, a couple of things to notice here. Your lungs are very stretchy, like a balloon stretchy, because the alveoli have elastic fibers, the little gold things that you see there. So each one's like a little balloon. When it inflates, it kind of contracts back on its own. So you fill them up and they kind of close on their own. So that's thing number one. They're surrounded by elastic fibers. Thing number two, they're surrounded by blood vessels. These are capillaries surrounding entire clusters of alveoli or air sacs. And I'd like you to look at the colors, pretty colors, red and blue, and think closely about arteries and veins. This is blood that is coming into the lungs to be reoxygenated and then to go back to the heart full of oxygen. So the blue stuff, tell me. Unoxygenated, yes. Arteries or veins? Arteries, because they're coming away from the heart. Here, at this site, the blood picks up oxygen and then it goes back to the heart, rich in oxygen. So the red stuff, veins. These are pulmonary veins. So in blue we see branches of the pulmonary artery, and in red we see sub-branches of the pulmonary vein. Make sense? I wish we had time to talk about everything that happens at that little interface, but we probably won't get to all of it. We'll get to a little bit. Okay, the alveoli are surrounded by fine elastic fibers. They also contain pores that connect them one to each other. It helps the pressure to be nice and equal throughout the lung. There are also alveolar macrophages. These are white blood cells that help keep the inside surface of the alveoli sterile. If any bacteria does remain in the air that you inhaled that did not get caught in the mucus on the way in, the macrophages should normally knock it out, assuming you don't have some sort of immune compromised situation going on. In this picture on the left, we've got a cartoon on the left showing a single intact air sac, and embedded in the wall. Why is my pointer still an ink dot? Let me go back to my arrow. Embedded in the wall, we see that most of these cells that are kind of tan with a purple center, those are the type 1 pneumocytes. They're just the main cells that make up the air sac. You can see in this edge view that they're flat. In green, we see some of our type 2 pneumocytes. Those are the slick stuff makers, our type 2s. And in blue, we see some of our macrophage, our white blood cells that wander around and eat bacteria that make their way in here. Next to this, right here, we have a capillary running. And this is, in this big inset image over here, our capillary over here and our air sac over here. We have the cell membrane of the air sac, and we have the cell membrane of the capillary, and that's all that separates the blood from the air. Now, I could get into a long, drawn-out discussion. We could do another hour on the physiology of this membrane alone. But what you need to remember in a very basic way is, like always, diffusion matters. Things are going to go from where there's a lot toward where there's less. The air in your air sacs has as much oxygen as the atmosphere, so there's more oxygen over here on the air sac side. Get back there. So the oxygen, which we will color, for want of something more sane, green, is more common here, less common in the blood. So here it goes out into the blood. CO2, on the other hand, which I'll color purple, for reasons known only to me, is really, really common in the blood at this point. So it will leave and go out into the air sac so you can exhale the CO2. So oxygen goes from the air to the blood, and CO2 will go from the blood to the air. The oxygen gets distributed to your tissues, the CO2 gets exhaled. And this is the respiratory membrane where the air sac meets the capillary. 2 cell membranes thick. 1 cell membrane is the alveolar membrane itself. The other cell membrane is the epithelium of the capillary. Lungs we can talk about right after a quick break. So it's about 2 minutes till now. Let's come back at about 4 or 5 minutes after the clock. See you in a bit. Okay, we are now talking about lungs. The lungs take up all this it, take up most of the space in the chest cavity except for an area known as the mediastinum. For here, I'm going to refer you to what I call the lung plate model, which is about to turn up on camera, so integrity folks, just hold tight. This model right here is the lung plate model, and the space between the two lungs is the mediastinum. It's where you'd find the heart. There are somewhere in the lab the other parts of these lungs, but you can see here on the side that the right lung has got two divisions separating it into top, middle, and bottom lobes, or superior, middle, and inferior lobes. And over on the left side we have one single division, so we get the superior and inferior lobes. You can even see primary, secondary, tertiary bronchioles and on down the line, but the space between those lungs would be the mediastinum. They are attached to blood vessels and bronchial attachments at an area known as the root of the lungs. And then the costal surface or outer surface would be on the front, the sides, and the back. So what we would see if we dissected open her chest without cutting into the lung proper would be the costal surface. Nice little transverse slice through the chest showing kind of what I just showed you there. Now, the upper tip of the lung is known as the apex. The underside, which sets on top of the diaphragm, would be called the base. And the hilum is the mediastinal surface where blood vessels attach. And you can see that on this model if you look right here. This little dent in the lung here, or over here would be the hilum. So in fact, it's a place where the bronchiole plugs into the lung. There's also a cardiac notch on the left lung, which I showed you, I think, on the camera, but just to be safe, since we're talking about it right now, I'll bring the left lung model back up. You can tell by looking at this one that it is a left lung because we've got only an upper and lower lobe, not a middle. And if I turn it, you can see the cardiac notch is right here, and that's where the heart would set. And this is likely to be one of the lungs that you'll see on the lab practical on the final. So just get used to that one. They're all over the place. They are, I believe, Tommy's lungs. The left lung is a little smaller. It's separated into two lobes by an oblique or angled fissure. You've seen that on the model a couple of times already. The right lung has three lobes separated by an oblique fissure and a horizontal fissure. The oblique is in an angle. Horizontal is more straight off horizontal. And each lung is separated further into segments. Commonly, if somebody has a portion of a lung removed due to cancer, then they will often have just a single segment removed instead of an entire lung. The right lung is divided into 10 segments, and the left lung is divided into 8 or 9 segments, depending on a little bit of individual variability. So 8 or 9, stop that. 8 or 9 for the left lung. Lobules, each segment is divided into lobules. Lobules are the very smallest of the subdivisions, and lobules get air brought into them by individual bronchioles and then the sub-branches of those. And I'm not really sure what big advantage we see of this picture other than we can see the mediastinum in between the two lungs where the heart's hanging out inside there. This is an interesting image. This is a photograph of real bronchi that have been plastinated. Some of you have had the opportunity to see shows like Body World or the Bodies exhibit where you have real people that have been plastinated. This is some bronchi that have been plastinated, and each level of branching has a separate color in there. So you can see the individual segments, although you're probably not going to pick out individual segments here, but you can see in this image that they've told you, and I suppose you're just going to get to trust them on that the right upper lobe is divided into 3 segments, the right middle lobe is 2 segments, the right lower lobe is 5 separate segments, the left upper lobe is commonly 4, and left lower is commonly 5. So this is the one that is either, 8 or 9 segments on the left, maybe 4 on the top, 5 on the bottom, or 4 on the top, 4 on the bottom. So there you get the 8 or the 9. Pleura. The membranes surrounding the lungs are called pleura. They're very much like the pericardium or on the heart. We've got a parietal pleura that's up against the thoracic wall and the upper surface of the diaphragm, and the visceral pleura connects to the surface of the lung itself. It's filled with a fluid much like the fluid surrounding the heart, and that fluid fills a very, very thin cavity we call the pleural cavity. It helps to lubricate the lungs as they move in the chest as you breathe in and breathe out. Mechanisms of breathing. Pulmonary ventilation actually has two distinct phases which you've been very familiar with since your very first breath. There's inhaling and exhaling. So, yay, surprise, surprise. When you inhale, you bring air into the lungs. When you exhale, you push air out of the lungs. Air being a mixture of gases. Pardon?
Some of these slides, if you didn't go over, do we not need to know them?
If we didn't go over them, you can pretty much skip them. Now, I say that, and I told you earlier, go ahead and flip through the chapters. You're, in theory, at least responsible for absolutely everything in all the chapters, but I'm going to go light on these, so don't pay as much attention to stuff that I did not directly cover. And when we get to pages like this, I will quite commonly take advantage of my ability to do that, and that, and that. And yay. Effectively what's going on here, and I want to really quickly explain what I just skipped through in the interest of time, because we're going to get a fair amount of the way through the digestive system today as well. When you inhale and go, what you're doing is you're lowering your diaphragm and you are raising your ribs. And I'd like you to equate that to pulling back on the syringe, pulling back on the plunger of a syringe. Maybe it's a syringe that you're taking a blood sample from a patient in. Maybe it's a syringe that you're injecting, I don't know, Worcestershire sauce, laced butter into a turkey at Thanksgiving. I don't know what you're doing with a syringe, but you're either pulling or pushing on the syringe. If you pull on the plunger of the syringe, is the space in the syringe getting bigger or smaller? Bigger. And you are, in fact, creating a partial vacuum in there. And as you lower your diaphragm and drop it down, you are increasing the space in your chest cavity. And as you raise your ribs, you are, again, increasing the space in your chest cavity. So the pressure inside your lungs goes down, and it creates a partial vacuum when compared to the air outside. So a lot of people have the idea that you went, and you sucked air into you. No, you did not. What you did was you expanded your chest, made a partial vacuum, and the entire weight of the atmosphere shoved air into you. You did not pull it in. It was shoved into you as you caused a drop in pressure on the inside. Lung collapse is properly called anaphylactus. It's caused by plugged up bronchioles, which would result in collapsed air sacs. Another way you can have a lung collapse is through a puncture in the wall of your chest, letting air into the pleural cavity, and that's called a pneumothorax. Pulmonary ventilation, when you inhale and exhale, depends on changes in volume in the chest cavity. And you need to understand that volume and pressure are inversely related. Basically, what I just said there is if volume goes up, then pressure goes down. And if volume goes down, then pressure goes up. So if one goes up, the other goes down. If you make more volume, then you have lower pressure, kind of creating a partial vacuum. So they are exactly opposite related to each other. Pressure changes causes gas to flow to equalize the pressure. Breathing in is an active process. When you inhale, you are moving inspiratory muscles. Now, the diaphragm is one of your inspiratory muscles. Another set of muscles that come to play here are lab questions that you need to be on the lookout for. These are muscles between the ribs. You've seen these back in our muscle chapter. I want to remind you of them now. Here in the Anna chest model, these muscles between the ribs, you have external intercostals that basically go this way. See the fiber length there, or the fiber direction there? And these going that direction are internal intercostals. It would be ever so lovely, but you get screwed on this one. It would be ever so lovely if internal intercostals help you inhale and external intercostals help you exhale, but I'm sorry, it's exactly backwards. Externals help you inhale, and internals help you exhale. So these that angle this way on our Anna model are external intercostals, and those that angle out are the internal intercostals. And you can kind of see that. The externals lay on the outside, and the internals are deeper. When they contract, when the externals in the diaphragm When they contract, the chest volume increases. And as they stretch out, the volume inside the lungs increases, so the pressure drops, and the air flows into the lungs. No surprise, it flows down the pressure gradient from high pressure to low pressure. And you can see that happening here. The diaphragm moves down, kind of like pulling on the plunger, quite literally. The ribs get elevated as the external intercostals contract, and they're going to lift up on the ribs. And you can see that this widens the ribs as well. In fact, kind of watch my chest here. See if we can get this on camera. What the hell? Yeah, that's close enough. As I take a deep breath in, my chest widens. It gets wider this way. Also, the diaphragm drops down this way, and both of those end up causing the chest capacity to expand, and the pressure, as the volume goes up, the pressure is going to go down. What the heck? That's not supposed to happen. I did not want a black screen. Exhaling, most of it is passive. Remember when we looked at the air sacs, they had those elastic bands around them? The inspiratory muscles, the muscles you inhaled with, will just relax. The chest volume decreases kind of on their own. Elastic recoil in the lungs lets those air sacs collapse. You saw a little while ago that they had those bands of elastic around them. And mostly, we'll just draw a line across here because that's what mostly happens. It's mostly passive. Mostly passive, but if you are doing, say, heavy exercise and you actually do a forced exhale, that's active. That last little forced exhale is internal intercostals pulling the ribs back down. And you can see that happening here. The external intercostals, where are they? Help to pull the ribs back down. All right. I'm not going to go over that. Physical factors influencing pulmonary ventilation. We have airway resistance, alveolar surface tension, and lung compliance, which is, again, stretchiness. As you attempt to bring air in those passageways, there is some resistance to flow. Alveolar surface tension, we talked about the air sacs, if they collapse on themselves, have to have some pressure to reinflate them, and then lungs are themselves partly stretchy, so you have to work a little bit to inflate those stretchy lungs. Surface tension, we talked about when our discussion of premature babies. The wet, moist surface of the air sacs, because they are indeed a wet membrane, the liquid attracts itself at a gas-liquid interface, and it resists any force that tends to increase the surface area of the liquid. In other words, your surface tension of the moisture of your air sacs tend to avoid inflation, so you have to overcome that resistance. And part of the help there is from this stuff that I talked about with our premature baby discussion. Surfactant is a detergent-like lipid protein complex that's made by our type 2 pneumocytes. Pardon? It's related, yes, ma'am. And if we have time at the end of the day, we may come back and circle back around to the cystic fibrosis discussion. It's an interesting discussion. They have trouble clearing out mucus. Yeah, it really is. It's fascinating stuff. Actually, really, really quickly, let me answer that. Most of us have the ability to cough up excess mucus because we have a thin layer of saline solution just underneath the mucus layer. Babies with cystic fibrosis don't have enough sodium pumps, so they don't produce a thin layer of saline underneath the mucus. So effectively, it's thick, goopy mucus stuck on the tissue, and it doesn't mobilize nearly as well. That's why CF patients often have to have these very vigorous massages to knock loose the mucus. Boy, that was the quickest CF lecture I've given in a long damn time. It is. It really is. Surfactant helps to reduce surface tension on the air sacs and discourages the air sacs collapsing, effectively making your lungs easier to inflate. And that's what's missing in those premature babies, and it causes them a problem known as infant respiratory distress syndrome, or IRDS. S, ERDS. So little bitty babies have trouble breathing, as we discussed earlier. All right. Lung compliance or stretchiness is a measure in the change in lung volume that happens with a change in pressure. As you change pressures, your lungs either fill up or unfill. And it's normally fairly high in a healthy person due to stretchiness of your lung tissue and alveolar surface tension. On the other hand, your normal lung capacity can be affected by non-elastic scar tissue, referred to as fibrosis, another issue with cystic fibrosis patients, reduced production of surfactants. Both of these, by the way, can be problems caused by smoking, because smoking can create this scar tissue and it can damage the type 2 pneumocytes that make the slippery surfactant that you depend on. And the final thing there would be a loss of flexibility in the rib cage. And a classic mechanism for decreased flexibility in the rib cage is bone scarring. One easy way to understand is if somebody's ever been in a car wreck in the driver's seat with the steering wheel bashing them in the chest, a lot of times the rib cartilage interface where the ribs meet the costal cartilages can end up with some scarring. Now, back in the fall when we did our session on skeleton and we were looking at ribs, and I did the last little one afternoon long session on forensics, I showed you a lot of things looking at the skeleton on how to tell male from female. And at one moment I showed you some ribs, and I was talking about this rib was from a young person, this rib was from a slightly older person, this rib was from somebody who was even older. And what we were looking at there were little spikes of bone where the rib joined the cartilage. Remember that discussion? When those spikes of bone grow into the cartilage, it's less flexible. So therefore, if they try to take a deeper breath, they can't. So as they lose flexibility in the rib cage, then they've lost lung compliance. A similar problem to what would happen with scarring from smoking or reduced surfactant. Ways to keep that in compliance here, or problems with keeping that in compliance are deformities of the chest, ossification of the costal cartilage, which is what I just mentioned, and even paralysis of intercostal muscles. There are all sorts of things that might paralyze your muscles between your ribs, and that would include bacterial toxins like tetanus. And that is the end of our discussion on respiration, and we will at this point dive into a discussion on digestion. I'm going to stop this recording and pick